Thanks, everybody. And so I will now segue to some of my own questions, and I encourage you sitting here in person and also online to be thinking about your questions as well. So starting with Sarah, one of the things that came to me, so I sent the panel some of the questions that I was thinking of, but I warned them that I might think of some more things. And a word that has come up a few times this morning is sustaining and sustainability. And so I'm going to use that concept to frame some of my questions to the panel. Because, I mean, we all know how hard it is to make things last, or whatever we're interested in. You were talking, Sarah, about how communities and organizations, that their behavioral changes at that level can play a role in supporting brain health. And so kind of two things connected. One, it would be nice if you could kind of spell out maybe how that happens. Because what struck me, I was thinking, well, some organizations are sort of new to this, or some communities, and some are more experienced. So if to the extent that that kind of how that plays out in different settings, this kind of behavioral change that you're talking about, and the challenge of sustaining it. Yeah.
I think the most important for every community, whether you're talking about the healthcare system, or you're talking about policymakers, or you're talking about individuals, is to understand that behavior change is possible and it can make a difference. That brain health and promoting brain health is possible and incredibly beneficial, so that each of the communities that we're talking about truly understand it is to their own benefit. They're not just doing this to help Helen or to help Sarah. They're actually going to benefit themselves from this. A simple example of employers. If an employer realizes that by bolstering their employees' brain health, by encouraging exercise, sustainable schedules where employees can get sleep, they themselves as employers will reap the benefits of a healthier workforce. That sounds very simple, but people don't operate from that premise. And so if each of the groups, for example, healthcare providers, if they truly understood that by helping people help themselves through this, that those are the interventions that would help them. It may take time for a healthcare provider to slow down and explain and sort of encourage people to engage in healthy behaviors, but in the long run, it will help the healthcare provider. And if they stop and listen to that person and find out what is of most concern to them, there are many things that could be addressed simply by addressing what is the one issue that matters most to the person in front of them. So it's thinking about brain health and the promotion of it, no matter where you are and what your role is. I think that could sustain behavior change, because it's going to help you as much as it's going to help the person you're trying to help.
I'm curious, and follow-up, because how many people, I think, feel like, there's an inevitability about aging and deterioration. So in AARP's work, how do you combat that and convince people that things can be different?
It's tough, because people do assume that cognitive decline is inevitable. And so we are working to engage people in a movement, a brain health movement, right? So that we can give the information to people based on evidence. We're not just, selling cotton candy here. The evidence actually shows it works. So based on that evidence, we're trying to pull the community together to create a conversation about, I would call it brain health action movement.
I think we have a question from the audience.
This comes from Rebecca D. Elon. She says, what is the role of the geriatrician in helping health systems adopt the 4M model? Geriatricians are the content experts in the care of older adults and frail elders. She thinks she asks, should there be geriatrician leadership in every health system?
I think that maybe it's directed at me, Faith. Is that right, Leslie?
Yes, yeah, because it's 4 M's.
Yeah. So thank you for the question. I'll flip it on its head a little bit to say that the age-friendly health system movement was started to ensure that older adults, including people with Alzheimer's disease and cognitive impairment, would receive evidence-based care no matter where they showed up in any health system and no matter what health system they showed up in, whether or not a geriatrician was there. Because we started with the reality that there just weren't, all the way you run the numbers and the models, there's no way for us to have enough geriatricians to be present for every older adult in the United States. So we actually, the movement was in many ways about filling that gap. We work very closely as a movement with the American Geriatric Society, which has the 5 M's framework. It's the 4 M's plus multimorbidity, which we are completely in alignment for. We did not start the movement to change the way geriatricians provide care. We know that geriatricians have this deep expertise. We completely honor it. And when a geriatrician is present and can practice the 5 M's, that is ideal. That's fantastic. The 4 M's are for the rest of us, the rest of our care teams that may not have a geriatrician, but need an accessible framework that reduces the complexity of the care that we've talked about as a panel.
Thank you, Leslie. I think we have another question from the audience.
This is from Gary Epstein-Lubo. He says, Kate McEvoy's suggestions are excellent about authorizing coordination of CMS and ACL. Thank you. To Kate and also Helen, could you discuss Kate's suggestion and also potential coordination of CDC with ACL and CMS? Specifically, to what extent can CDC's authority under the BOLD Infrastructure Act to provide local and national education about dementia be expanded so that CDC could work with ACL and CMS to support dissemination and implementation of evidence-based interventions?
So the BOLD Act has just started to be implemented in the last couple of years, and there certainly is coordination between the aging network and the public health networks. Much of the focus has been on risk reduction, but there is a BOLD Center of Excellence on caregiving, and they have a conference coming up in mid-June. And many of the topics that are covered are programs that ACL currently runs. The BOLD centers are focusing on and disseminating. And I think both approaches are out there. You know, we have the Aging Network, which is a great resource for older adults in America, and we have the public health networks, and they've been separate for many years, and we are now seeing this movement towards age-friendly public health systems and a recognition of the Older Americans Act programs as a source of resources, information, and essentially risk reduction programs for older adults. So I do think there's an opportunity to work together between those two programs. With regards to the link between the Older Americans Act services and CMS and Medicaid programs, this has been tried. Richard and I worked on something 10 years ago that was in this space, and I think, you know, if you focus too much on cost effectiveness, you lose sight of the fact that sometimes the right thing to do is the right thing to do. So thinking into the future on how these programs could be better coordinated. I think it shouldn't just be that the Older Americans Act is providing services because it saves money for Medicaid. We can't focus on that. It should be that there is a need for services for a segment of the population who the Older Americans Act services provide services to, that will help them to continue to live in the community, to get the services and supports that they need. And it is a population that may at some point be eligible for Medicaid, but at this point isn't. So the agencies do speak together. There is an interest in thinking more about these coordinations. The CMS administrator, I should mention, is having a listening session today from 1 to 2 o'clock, and I'm sure that these issues will come up. So it's something that I continue to encourage people to talk about and to think about how we could do.
Yeah, I really appreciate Helen's leadership on this and all the remarks you made, and I also appreciate the questioners layering on of the CDC resources. I have to say, having come up as an attorney through the Agency on Aging system, and then having become a Medicaid director, I'm just acutely aware of unrealized opportunities here. And I do think Medicaid tends to be very insular in terms of its kind of orientation to traditional service array under state plans. There are many opportunities for a specific intersection. As I said, one example is Medicaid coverage of funding for aging and disability resource centers, long championed feature of the ACL agenda around that, better equipping consumers to optimize their own resources, whatever profile that takes. And I absolutely agree with Helen that the center point should not be saving resources for the federal government and states. It should be supporting people in accessing the services and supports that they need. But I am constantly struck by this sort of failure to thrive amongst those different strands of funding. And if there could be attention to enabling formal braiding of those pieces, I suggested a couple of means of doing that. I do think it would give permission and impetus to states to do more of that, because coming out of the public health emergency, I think states are very, cued to that. There's also been new channels among Medicaid agencies and public health agencies that I think just never existed before. So leaping off that, I think this is a moment in time where that really could thrive in a more substantial way.
Thanks, Kate. And Kate mentioned failure to thrive, which gets me back to my sustainability. And I have a question for you, Leslie. You talked about implementing the age-friendly initiative at scale. And I was hoping you could tell us more about how you're evaluating the age-friendly initiative, and especially how you are thinking about isolating the impact of age-friendly from other factors that could be affecting patient outcomes?
In terms of evaluating and measuring at scale, as I shared, what we are capturing is our reach. And understanding, because we know that each of the 4 M's is deeply evidence-based. We are counting and capturing how many people are reached with that evidence-based care. And we also have captured, and I can put the link in the chat, a number of case studies where health systems are capturing the impact on outcomes, on length of stay, on rates of delirium and incidence of delirium, on different aspects of the 4 M's and the impact. So we're measuring both the reach and also the impact. In terms of your second question, could you remind me, Faith, of the second part of your question? I want to make sure that I answer that one correctly.
Yeah. So I was the one part was about implementing at scale. And evaluating it was part of doing that. And then thinking about sustainability, which I think you also mentioned. I guess, how evaluating age-friendly initiative can help with the sustainability of that initiative. And I guess just your thoughts and the evidence that you've found so far.
Yeah. And, I want to be really, really clear that, and I think you also were asking about isolating, right? Isolating out the impact of the 4 M's relative to other aspects of care. Our interest here is improving the care of older adults and ensuring that the 4 M's are being practiced. It's nearly impossible to isolate out, because there's so many moving parts in a health system, exactly what, if there are other elements, other interventions that are taking place. In fact, in many ways, we welcome other interventions that are having a positive impact on older adults. So, for example, the age-friendly health system movement is working very closely with with ACEP and the Geriatric Emergency Department accreditation, and also with the American College of Surgeons and the Geriatric Surgery verification, to ensure that the best care is being provided no matter where an older adult is showing up. So in many cases, we're actually welcoming those all of those interventions, so that when an older adult and their caregiver with an older adult with Alzheimer's disease or a related dementia and their caregiver show up in the system, no matter where, there's sort of this well-knit system of evidence-based care every single place that they are. And I mentioned, and in terms of sustainability, what we've really found is the key to sustainability is allowing this space for systems to be able to adapt the 4 M's to what works best in their culture, what works best with their care team, what works best in their system. Anne Arundel Medical Center, which is in Maryland, for them, the what matters piece just took off like wildfire in their health system. It was VM that drew in the system for an organizational change and adoption of the 4 M's. So that was right for them. And for them to engage their entire system and their patient and family advisory council to learn how to ask what matters. That was the system, the change, the 4 M's would not have been sustainably adopted at Anne Arundel Medical Center, as an example, if we hadn't given them the latitude to figure out where to start this work and what worked best for them. So we've really found that, combined with tools around quality improvement, which we know have an autonomy for care teams to do this work, which we know has a positive impact on joy in work. Without those two, I don't think that the 4 M's would have been as sustainable and as broadly adopted as they have been.
Faith, I just wanted to jump in on your sustainability and evaluation question. So AARP worked with US Aging, the used to be N4A, the administrations on aging, that are implementing Dementia-Friendly America, creating a network for when communities themselves want to become dementia-friendly and the steps they're taking to become dementia-friendly. We created an evaluation mechanism so that communities could determine whether or not their initiatives were working and effective for people with dementia, to the point of your sustainability, that if you can show that is actually helping and effective, that we want to encourage those communities to share those practices and to continue them. And so I encourage us to think about the evaluation mechanisms put in place for dementia-friendly communities to do those kinds of evaluations designed to be simple, inexpensive evaluations, improve its outcomes.
That's great. That's great to know. We have another question from the floor.
This is from Jenny Chin Hansen. She says, Leslie, are there any communities, health systems already providing care and in partnership with high-risk, diverse populations that have shown particular progress in the secular movement of the 4 or 5 M's? Does system and community adoption exist so that brain health / mitigation of dementia risk is more intrinsically practiced and adopted?
So wonderful, a wonderful question, Jenny. And yes, and in fact, I'll go back to Anne Arundel because they have done this work in a very deeply connected way with their community and their community-based organizations. There's another system in Michigan that has worked very closely with their community-based organizations, so that when an older adult or a person with Alzheimer's disease or a related dementia shows up in the emergency department, they are also connected with community resources. So many systems have, I'll say, needed, almost more than chosen, to connect with community resources in their adoption of the 4 M's. We now have a number of systems, including UCLA, I believe it is, that, and maybe UCSF as well, that are working with community health workers as well, that are going out, and Dr. Elizabeth Ekstrom is working on this, having community health workers go out into the community with and work using the 4 M's framework to provide care. So it does come out of necessity of health systems realizing that in order to do this effectively, a partnership with community-based organizations is essential. Faith, can I add one other comment relative to sustainability?
Sure.
That Sarah was starting to get to, and I just want to make a even, I guess, finer point on it, which is part of this is ensuring that the practices that we are building for sustainable practices that we are building are having an equitable impact across race and ethnicity. What we don't want to do is build sustainable practices that increase disparities. So an essential aspect of this work is measuring process and outcome by race and ethnicity. So once something is hardwired and we're focused on sustainability, again, we're focused on sustainability of work, of processes, of collaborations that reduce disparities and support equity.
We have one, before we go to the question, let me just comment on what you just said, Leslie. I think you know that's something you and I have talked about a lot, and it was interesting. You had that slide that was pretty complicated, so people might not be able to absorb it quickly, but where you showed the racial and ethnic differences in the implementation of 4Ms. And I was going to ask you about that, but I'm interested that you mentioned that people are working with community health workers, hospital systems, because that's kind of my umbrella concern, is just thinking about how we take these different recommendations and initiatives and things and tailor them for specific communities and, people where English is a second language and other kinds of things. And so I'm really encouraged by that notion of health systems working with community health workers. I think that's the right direction. So to the question from the floor.
This one comes from Emily Williams. What are the 3 most important services and supports, including for caregivers, that could help people remain in their homes and communities, irrespective of the program that provides them?
I guess it's a question for anybody, right?
What are the 3 things of services that would keep people in their homes? The number one thing is getting the right information at the right time to the right people. Caregivers and the people living with dementia have zero idea how to approach the system. They do not even know what to ask. And if we can figure out how to get them the information of the services that are available when they need to know it, that is the number one thing that we could do.
Some of the research we've done has looked at caregiver characteristics and individual characteristics and as predictors of nursing home placement. This is for the entire older adult population, but it rings true for people with dementia, of course. And the strongest predictor, controlling for everything else, was the physical strain, undefined physical strain. And so that might be, and something we've looked at is lifting, transferring, moving the person that the caregiver just cannot ambulate that person anymore. It could also be, and what we've heard, night wakings, incontinence, the things that put a physical, at some point it becomes physically too difficult for the family to keep the person at home. And then the behavioral and psychological symptoms of dementia, which, to Sarah's point, is an education piece that the caregivers need to know what to expect, how to address some of these behaviors, what to do about them, and then have the physical supports in place to meet the needs of the older adult with dementia.
So I would add that I think related to both of those, it's not three, it's one, asking what matters to the person with Alzheimer's disease or related to dementia and the family caregiver. And we define family very broadly, however the person defines family. Asking and acting on what matters. And that will lead us to know, is it, as a caregiver, I can't bear to keep getting up every hour, or I can't lift my husband off the floor anymore. If we take the time to ask and act on what matters.
I think that is so profound, and there should be a full stop after that statement because it is so determinative. So wholeheartedly agree with that. I would say, building on that, what do people want? The person-driven outcome measures that influence a plan of services and supports. The way that we have traditionally paid for personal care supports, the home health model, which is a rigid block of hours, circumscribed payment, very limited availability under the Medicare benefit, it is not the right way to approach that. And the elasticity and the flexibility and the personalization of a self-directed approach where the personal care assistant, it can be episodically available when someone needs it. That seems really important from my standpoint, as are publicly funded respite benefits. And again, that goes back to the variability of coverage under the waivers, striking differences among states and long wait lists, I know, but that respite benefit as a deliberate companion to the services for the person who is the principal recipient of services is a companion piece that is essential.
Thanks, everybody. And taking another question from the floor.
This one comes from Gary Epstein-Lubo. Thank you, Kate and Helen, for great and hopeful suggestions. Helen, the successes of NAPA are excellent and are a great example of coordination and collaboration. Given the achievements Leslie describes with the Age-Friendly Initiative and Sarah reports regarding brain health education, are there additional opportunities through NAPA and/or with HRSA to build further collaboration of education efforts? Faith's point is essential about this education being tailored and directed to communities most at risk.
So the short answer is yes. I think yesterday Terry might have mentioned the geriatric workforce enhancement programs that HRSA runs, and Joan Weiss has been a fabulous partner from day, talk about a person who's been working on this since day one. And they've used that network to spread new practices, to make sure the field is up to date on what is happening. Risk reduction was added this year as we added a new goal to the national plan. So that certainly is a network, but there are a lot of components of education that go beyond what the federal government has a hand on. And so something that we've wondered about is how we can get the professional organizations to build this into the requirements for education, how they can spread the word. Some of the states do have requirements on dementia education or geriatrics education for their various workforces, but it goes beyond what the federal government can do. And this is a place where I think partnerships and the non-governmental organizations as partners spreading the word and bringing people in would be essential to making sure that everybody has the information that they need.
Yeah, I really appreciate that comment, especially that last part. And I think one of the most humbling aspects of serving as a Medicaid director during the pandemic was realizing the extent to which, when we ask people, what's your trusted source of information? What is the pathway you find credible and persuasive? It is not government. It is not the federal government. It is not the state government. It tends to be, when you ask older adults and caregivers, it tends to be peers. It tends to be physicians. And I don't think, for all the reasons that we've discussed, physicians don't tend to be well enough equipped, perhaps to act as the most expert advisors on a lot of these complex issues around benefits eligibility and the like. But I think the pandemic stands for the proposition that due to multiple factors of the environment, notably structural racism, there are many communities who are going to want to work from a more naturally occurring basis, peers sharing messaging and tailoring the supports in a way that can be relevant, can be linguistically appropriate, can feel that, again, there's a sense of identification. And I'm really interested in building out the concept of community health workers to act as people with lived experience that we've more seen in the behavioral health community for families experiencing dementia, because I feel like you don't know this path until you have trod it. So I think thinking about how to build that into value-based payment models and to routinize that, for instance, in our health centers, building on past experience that they have had with it, I think that would be a great direction to go, as opposed to the sort of state and federal governments regarding themselves as the center point of information distribution.
Sorry, I forgot one thing that I should add. Thank you so much, Kate. The federal government can, though, be an incubator for some of these ideas. So I think tomorrow ACL is actually having a webinar on the Wisconsin State Dementia Care Specialist Program. And the dementia care specialists in Wisconsin are community-based health providers who are helping people in a culturally appropriate way identify dementia. So they are a trusted source of information integrated into the community that can get to that very first part of that dementia pathway, which is helping families and the individual recognize the symptoms and get them in for a diagnosis. And that was funded with an ACL grant. So while we can't do everything, I do think there are opportunities to support the innovation in the field and to tailor innovations to what the communities need, and hopefully to spread and disseminate that information to the larger networks.
And I know we're almost out of time, but okay. I think that the committee should think about the National Institutes of Aging researching the benefit of Medicare creating a payment stream to community-based organizations who provide social care to services to people with dementia through training and partnerships with healthcare providers. So that healthcare providers are working with the community-based organizations to provide services similar to what you're describing in, it sounds like, the Wisconsin program. I think that that would be a tremendous opportunity to find out how effective the partnership of healthcare system deliberately partnering with Medicare dollars for a community-based organization could be.
I'm going to add a friendly amendment to your recommendation, which I think is a great one, Sarah, which is that we know the kind of capacity of community organizations varies considerably, and that in communities of color, in particular, they're often overstretched and under-budgeted. So I would hope that Medicare would also provide some funding somehow, or foundations would, to strengthen those organizations so that they could really participate in those kinds of partnerships that you're describing. While I have the floor, I have a question for Kate. Kate, Sarah said something about how people don't know how to approach systems, and you've talked about that as well. You were talking specifically about how people are unclear about like what coverage is available under Medicare, and we also know that people just have real information gaps that and often a limited ability to kind of advocate on their own behalf. And you've already kind of partly answered this, Kate, but I was interested in some of your ideas about consumer literacy. And I was thinking about COVID. And we see how hard it is, clearly, to communicate information to people. It's not as simple as maybe public health used to think it was. So, and you've mentioned some of your thoughts about like working with community health workers, and I wondered if you had more to say on that point.
Faith, I totally appreciate following up on that, because I think this is so foundational to actually meeting people where they are. What we have done for the last 30 years, and I've been an instrumental part of that at the state level, is relied on static written resources that are, originate from, government sources. They may not be available at the moment in time that they're needed, even if someone has any idea, how to access them. And I think Sarah talked about the fact of how at sea people feel about that. So I think we've got to be conscious that the self-actualization of the need for information is unlikely to arise in sort of a precatory way. We need to have a mechanism to wrap around someone as this is emerging, when a diagnosis occurs, when the stressors of caregiving become acute. I think CHW approach is definitely one potential. That would have to be built into a non-fee-for-service payment to primary care or to health centers, or within a duals demonstration type of arrangement, in order to make it viable, because as a standalone service, I think it has not been taken up substantially, other than in Minnesota, to my knowledge. But I also think that there are great progenitors in the Older Americans Act work that's been done by ACL. The whole state health insurance program that was part of, equipping consumers on Medicare and Medicaid, that has continued to date and has relied a lot on expert volunteers. And I know AARP has done a lot of this work also, but that strikes me as being another untapped resource with respect to support for individuals with dementia, around, an individual being able to support a family at that moment in time that they need it, on a peer basis. So I think CHW approach, that Older Americans Act funded state health insurance programs, these are potential pathways. And as much as we can kind of get away from thinking we can, equip people with resource guides, or even the No Wrong Door, which is not necessarily accessible, I think the final thing I'd say is, if we are able to solve for the long-term care insurance issue by making that a payroll benefit, that would be a mechanism, I think, to helping workplaces, be a conduit for information in ways that only very, very progressive big corporations have done. And I just don't think that that is as commonplace as it could be. And that would help to routinize that.
Thank you. We have a question.
Hi, Dr. Mitchell. It's Peter Holman from Brown University. If you have some other things you want to explore with the group, I'll just step aside. But otherwise, I was wondering if I could make a couple of comments.
No, go right ahead.
Thanks.
Yeah.
So as a primary care physician in my group, one of my main responsibilities is trying to work towards transformation in our primary care practices. I hope that we would think about doing some comparative effectiveness analysis of some things. For instance, I've heard things that primary care clinicians should potentially do, and I think the key point that's also been made is that teams are essential to having effective primary care practices. So expanding primary care first and other initiatives that create teams, expanding our education of teaching physicians how to work with other members of the team. Working with community health teams, that's something that's very novel for people. It's very important, but I think that is something we really need to explore further, and contrast that, for example, to asking a primary care physician to talk about brain health. Because I think that's something that most primary care doctors have been doing from day one. They haven't called it brain health. They've talked to cardiovascular health. They've talked about general health. And almost everything in there, as important as they are for prevention of dementia, is generally good advice that people have been giving for a long time. And if you ask people to spend a few more minutes, believe it or not, spread out over the entire universe for primary prevention, that's an astronomical cost and burden on the healthcare system, and primary care doctors, frankly, are resenting what they're being asked to do on a regular basis. So I think comparing that to some of our activities. The other point I wanted to make is a really narrow one, but Dr. Elon asked about geriatric expertise, and I think that's not so much a question of being a geriatrician for all the patient population. That's clearly completely not feasible, and I don't foresee a time that that's going to happen. But one of the things that the American Geriatric Society has commented on, and several times in Medicare physician fee schedule proposed rule, is that it would be appropriate for a Medicare shared savings program to have a requirement to have somebody that is involved in it at a leadership level, whether it's a board member or an advisory committee or something like that, that has geriatric expertise. And there is a direct parallel for that. Medicare Part D plans must have a geriatric pharmacologist and must have a geriatrician on them. So there's no reason, when you have an even bigger program than just pharmacy, you have all of the Medicare Shared Savings Program, that you could not have a requirement for MSSP and other type services to have expertise in geriatrics. So I apologize if I'm more reacting than asking, but thank you for giving me this opportunity.
No problem. Anybody want to respond? Or any?
I think we need an easy button for primary care physicians so that they hit a button and they got a referral they know is solid, so that there can be coaching by other adults to adults or other community-based organizations where they have the time and the attention to be able to counsel a person. I think that one of the questions about brain health is, why do we think people are going to do anything different in their behaviors if a doctor should tell them that they need to exercise? Because you're telling them that they need to exercise for their heart. If people understood that they could delay onset or severity of symptoms of something that they fear. Dementia is the single greatest feared disease of older people. If they really understood that they could make a significant difference in the quality of their life by instituting these behavior changes, even if they have the disease, I think it would make a difference. And a primary care physician is always the first place we turn and say, fix the problems, right? And you can't. But that's why you need the easy button to the referral to the community-based organization that has the time and the ability to give that person what matters most to them.
And I'll just say, I said lead with the people. The people are the most important part, but we do have this backup system, which is electronic health records. And we have the technology to, my watch will ping me and tell me to meditate once a day, or get up, you've been sitting all day. So why can't the EHR from my primary care physician send me a note that tells me, did you know that if you got 8 hours of sleep, you might delay, your cognitive performance would improve. So thinking about how to not put everything on the individual to know. They can know so much, the geriatricians can know so much, but make sure we build those systems behind them that if the individuals fail or they don't have everything they need, there is a backstop. So I imagine in the 4M system, some of those systems do have these things built in. So it reminds people, I know at the VA, there are pop-ups in the EHR system that will tell you this person has dementia, so that every provider knows that that person has dementia. So making sure that we are building the workforce, but also exploiting all of the technology tools that we have in place to be that next level and make sure that it spreads. These things that we know work, but maybe we don't have enough time. We can use them.
So I would just say yes, yes to both of those, and just two more pieces to respond to your really important point, because I really do honor that I keep turning to primary care and saying, well, here's another piece of work. Do this. That in the age-friendly health system movement, we are starting to work with regulators, policymakers, accreditation, certification bodies to understand how practicing the 4 M's can actually, what can we take off the table in terms of measurement burden, in terms of requirements around care that's delivered? Is there any way to reduce the burden on the workforce, really holding that as a priority instead of just keep layering on top? So we're starting to do that. We're starting to do that work, ask those questions, and have those conversations. I also would say that as you pointed out, we've been talking about. I know every time I've talked about care teams, and that we did work in Indianapolis with an age-friendly health system where all the annual wellness visits were completed by an NP, and it was really they found that model worked better for their community, and so just thinking about care teams and also about where nurse practitioners. CVS Minute Clinic has adopted the 4 M's across their 1,100 minute clinics at the nurse practitioner model, or has been a nurse practitioner model. So thinking beyond, including physicians and nurses and other workers. And I really honor your comment in the chat, Dr. Inouye, about making sure that geriatricians are at the table for the important decisions pertaining to care for older adults. None of this is about precluding geriatricians for those critical conversations of care. So thank you for that, Dr. Inouye.
Terry, did you have a question?
Leslie made my point.
Oh, she made your point. We have just a few minutes left. So what I want to do is ask each panelist what your questions would be for NIA's research agenda. What do you want them to work on related to your work? Says taking notes over there. Anybody want to start?
I'll jump in and say I think that they should research, and you may have heard this before from me, Medicare creating a payment system to pay for social care systems or social care services through community-based organizations in partnership with healthcare providers. And just to jump in to say, Dr. Meena Seshmani talked about trainings. I think that that's what's important, that they create systems of training for caregivers, for people with dementia, and for healthcare providers through these partnerships.
I would, so again, yes, and agree with Sarah for sure. And asking wanting to understand how can we reduce the burden on our workforce so that what really matters to people with Alzheimer's disease and related dementias, to all older people, so that care teams have the time to ask and act on what matters and the essential elements of care. So what can we take away so that what really matters to people can be the priority for the person as well as for the care team?
So I think both of those comments are wonderfully put, and tremendous priorities. From my standpoint, I think what would be extremely helpful is for NIA to elevate existing experience and evidence around the value of rebalancing long-term services and supports toward community focus, in that it represents an intersection of consumer preference, it optimizes financial interests of both the federal and state government, and it's an opportunity to free up resources, given that on the whole, and there's important caveats here, but on the whole, it is less costly to serve people, even with extensive supports in the community. It's an opportunity to free up resources for reinvestment in care coordination and peer supports and these and the attention to social drivers of health that Sarah referenced. There's longitudinal data through the Money Follows the Person demonstration and the Medicaid waivers that abundantly illustrates the synthesis of these various aspects. And I feel like that, bringing that up to the fore and broadcasting it would help to heighten the level of attention and urgency at the state gubernatorial level, towards enabling sustainability of these features of the care system that we all want to see occur and are often hampered by lack of funding.
All right, it's a little tricky for me because these are my friends and neighbors over at NIA. But something I've been thinking about, the Indian Health Service just put out some new Alzheimer's grants, and we've been learning more about, in particular, the Eastern Band of Cherokees. And they've done some wonderful work building a system where the geriatricians providing care to the older adults are connected with them when they go to the hospital, and then when they go to the nursing home. And it really got me thinking, like, if we started from scratch and built a health system that worked for older adults and people with dementia, what would it look like? Could we think through, set it up, make it work in such a way that it met the needs of the population, and then backed up to look at what we have and how we make those things? And it's obviously a very optimistic viewpoint that, you could set it up. It would be costly, it would be time consuming, but we really are trying to fit this round peg in this square zigzag hole, and it's not working, and we're trying to change things so it does work. But what's the optimal situation, and how could we set up the optimal situation? And I think it'd be helpful to think through what the components of that would be, what it would take to get there, what it would cost, the time, the training, et cetera, and then to use that to inform further research and policy.
Thank you. Thanks. A perfect ending note. I'm always the optimist, right? What would the system look like if we set it up so it really worked for people? I want to thank the panel for their great comments and thank the audience here in the room and also online for your great questions. It's been a really stimulating session, and I believe we are about to go into a break, but don't leave us, because then we're going to have a general conversation among the planning committee members with people online, right, about next steps.